Hi everybody, my name is Mitchell Farmer and today we're going to be covering Laboratory 3 of GI, or also known as the abdominal cavity and the GI tract. This is one of my favorite series of labs actually, but before we dive into it I wanted to talk about a couple definitions just so that you can kind of follow me better as we move through this next lab. The first thing I wanted to talk about was mesentery. Now, mesentery is a double layer of peritoneum enclosing a viscera, for example, the stomach, and connecting it to the posterior abdominal wall. As you go through your dissection, your cadaveric dissection, you'll notice a lot of things are hanging off of mesenteries. There's the transverse mesocolon, there's the sigmoid mesocolon. Those are both mesenteries. All of the intestinal, or all of the small intestine are off a mesentery. Then there's omentums, which are double layers of peritoneum extending from the stomach to other viscera. So there's the greater omentum, which hangs off the stomach. I'll discuss that more later. And then there's the lesser omentum extending from the stomach to the liver. And then finally, there's peritoneal ligaments. Now, ligaments are all double layers of peritoneum that aren't called mesentery or omentum. Generally, they extend between organs, various abdominal viscera, or between viscera and the abdominal wall, generally the anterior abdominal wall. I will discuss about some ligaments later. Now, what we are looking at here is an anterior view of the peritoneum. This is anterior. Here we have the liver, transverse mesocolon, descending colon, sigmoid colon. Superiorly, we have the esophagus entering the abdomen, and inferiorly, we have the bladder, as well as the uterus and the rectum, as well as the anal canal. Now, once again, before diving into the dissector, I just wanted to talk about a couple points regarding intraperitoneal, infraperitoneal, and retroperitoneal structures. So, since the abdomen has so many organs, they're kind of all over the place. Some of them are intraperitoneal, some are retro, some are infra, also, which is also sometimes referred to as being extraperitoneal. What I first want to start with is retroperitoneal structures. So I'm going to rotate my model posteriorly, and here we have visible basically our relevant retroperitoneal structures. Starting superiorly, just zooming in here a bit, starting superiorly, and once again we're looking at the posterior view of the model, we have a bare area of the liver which isn't covered in peritoneum. Now the liver is generally considered intraperitoneal, but there is a area of the liver that isn't covered by peritoneum and is, I guess you could say, retroperitoneal. Then there is the kidney and the associated adrenal gland, which I don't have present here, but both kidneys and their respective ureters are retroperitoneal. There is the pancreas, the pancreatic head, and the pancreatic body are retroperitoneal, whereas the pancreatic tail, highlighted here, is intraperitoneal. And then there are the second, third, and fourth parts of the duodenum are all retroperitoneal as well. There's also the rectum is retroperitoneal, and the ascending and descending colons. Between them, the transverse colon is on the transverse mesocolon and is therefore intraperitoneal, and the sigmoid colon between the descending colon and the rectum is on the sigmoid mesentery, which is makes it intraperitoneal, because if it's on a mesentery, it's intraperitoneal. And then two items that I don't have shown here are the abdominal aorta and the inferior vena cava. Those are both retroperitoneal structures. Now, infraperitoneal, sometimes also referred to as being extraperitoneal, there's a couple structures that lie in the pelvic cavity and are coated superiorly by the peritoneum, which I've now highlighted. There's the bladder anteriorly, and in the case of a female, there is the uterus as well, between the bladder and the rectum. Now that I kind of orientated you to what's intraperitoneal, what's retroperitoneal, because those concepts are going to come up over and over and over throughout GI. I want to move into the actual dissector. I'm going to start by removing the peritoneum to expose the underlying organs. The first thing that you see, and the most prominent thing you could very well see in your cadaveric dissection, is the greater omentum. The greater omentum is kind of the policeman of the abdomen because it migrates to areas of infection and inflammation. And actually, in the case of your cadaveric dissection, it may be adhering to an isolated section of the abdomen. So instead of being draped out all beautifully like this, it might just be all bunched up right here instead, because that may have been where an infection was before the person passed away. Now, the greater omentum extends from the greater curvature of the stomach. This is the stomach. And this area here is the greater curvature. So extending from that greater curvature is the greater omentum. And it also extends from the first segment of the duodenum. Now, speaking of the stomach is composed of two curves. I'm just going to remove this section of liver here really quick, as well as these ligaments. All right. The stomach has two curves. As I already stated, there's the greater curve, and then there is the lesser curve on, I guess you could say, the medial aspect of the stomach. Extending from the lesser curve is the lesser omentum, something I'll get to talking about here. But first I wanted to discuss the gross anatomy of the stomach. There is the fundus of the stomach, which is the superior aspect of the stomach, kind of roughly around here. The superior aspect of the stomach, and it usually contains air, which is visible under the left hemidiaphragm on a radiograph or x-ray, an abdominal x-ray. You'll see kind of a dark area which represents air under the left hemidiaphragm. Then there is the body extending from the cardiac orifice, also known as the lower esophageal sphincter, or LES, to the level of the angular incisor, a notch of the lesser curvature. So kind of from here, the cardiac orifice, roughly, extending down to the angular incisor. Now, the angular incisor isn't super well shown here, but it's roughly around this area, and you'll probably be able to see it quite well on your cadaver. After the body of the stomach, there is the pyloric antrum, extending from the angular incisor to the proximal portion of the pylorus. So right across here, that's the antrum. And then finally, get rid of that drawing. Finally, there is the actual pylorus, this section highlighted here, which contains the pyloric sphincter, which you can actually feel internally if you feel the pylorus section of the stomach. Now, backpedaling to discuss the lesser omentum. The lesser omentum is kind of a double layer of peritoneum extending between the stomach and the liver, as well as between the duodenum and the liver. And those two structures known separately are the gastrohepatic ligament extending between the stomach and liver, or the hepatoduodenal ligament extending between the liver and the first segment of the duodenum. Now, the lesser omentum, one of the reasons it's important is it helps define the anterior boundary of something known as the lesser sac. Now, the lesser sac is kind of hard to wrap your head around because it's not something I can just click on and highlight and show you, because it's a space or an area, a cul-de-sac cavity, and it has a next opening that leads to the rest of the greater cavity. So you have this cul-de-sac in here, which I'll go over the boundaries here in a second, and through a space approximately here, it connects to the rest of the peritoneal cavity, which is formed by the rest of the peritoneum. But first, the boundaries of the cul-de-sac known as the lesser sac. I'm just going to move so we have a posterior view of my model here, just so we can kind of cover it a bit better. And I'm going to add in the spleen and the splenic artery. All right. So the lateral boundary of the lesser sac on the left side is the spleen. So imagine a space extending from here to the spleen so far. On the right side, the right lateral boundary are kind of folds of peritoneum in the right free margin of the lesser omentum. So you see how that's kind of just a free margin of this lesser omentum. That creates a narrowing known as a narrowing and an opening extending from here through to the rest of the peritoneal cavity, known as the omental foramen or the epiploic foramen of Winslow, which I'll discuss in more detail shortly. So that's the lateral boundaries. The anterior boundary is the stomach, highlighted here, as well as the lesser omentum. And the posterior boundary is the pancreas. So just kind of imagine, you can kind of see it here, space between the lesser omentum and the pancreas, as well as the abdominal aorta, not shown here, and the diaphragmatic cura, as well as kind of some lesser area or some lesser anatomic things like the splenic artery and the celiac artery. And finally, the superior boundary is the liver, up here, highlighted here. And the inferior boundary is the transverse mesocolon, which unfortunately I can't show you because the transverse mesocolon isn't present in this model, but it's basically the mesentery which is suspending the transverse colon, which I have highlighted here in blue. Now the lesser sac has several communicating recesses. So kind of spaces that are connected to the lesser sac. There is the superior recess extending between just going to wrap around here, and I'm going to add back the peritoneum for this. Sorry. So there's the superior recess extending superiorly between the inferior posterior surface of the liver and the diaphragm. So we have this area here, which is the inferior surface of the liver, and we are looking at a posterior view, so we already have posterior. So this area covered in peritoneum here, that is continuous with this area, which is the lesser sac as I outlined, and that is known as the superior recess. And then there's the inferior recess, which I have a harder time showing, but it extends to the greater omentum posterior to the stomach. And then, as I've said before, the lesser sac is continuous with the greater sac through the epiploic foramen of Winslow, which I will now show you. Just pull this up. All right. Now the epiploic foramen of Winslow. It's an opening on the right free margin of the lesser omentum. So you remember how I said you have this lesser omentum, which is highlighted, and then you have this right free margin right here. Kind of just show you right there. So it's an opening that extends from the inferior vena cava posteriorly. Like, let's say I was putting my fingers through that opening. If I put my fingers through that opening, posterior to my fingers would be the inferior vena cava, and anterior to my fingers would be the the portal triad, which includes the hepatic portal vein, the common bile duct, and the proper hepatic artery. I'm just zooming in some more here and moving inferiorly. So you can see how a space, and I'll hide this piece of liver too, you can see how a space exists between the inferior vena cava and those three structures right here. That space is the epiploic foramen of Winslow. And that allows the lesser sac to communicate with the rest of the greater sac or the rest of the peritoneal cavity. And why all this is important will become shortly apparent. But for now, I wanted to touch on, kind of while we're looking at this view, I wanted to touch on the spleen really shortly here. So the spleen, as you know, or as you may not know, is located in the left upper quadrant, which will be important to know eventually for physical examination. Now, unfortunately, a lot of details are lost on my model regarding the spleen, but basically, the gist of the spleen is that it's suspended between the stomach and the left kidney. I'll add in the left kidney, just for reference of where the structures are. But between the spleen and the stomach, there's a ligament known as the gastrosplenic ligament. And between the spleen and the kidney, there's a ligament known as the splenicorenal ligament. Now, the gastrosplenic ligament encloses the short gastric and left gastroepiploic arteries and veins, which will be discussed in a later lab whereas the splenico-renal ligament encloses the splenic artery and vein, also discussed in a later lab, as well as the tail of the pancreas, which I've highlighted here. So you can just imagine a ligament extending between these two organs, or between these two viscera. Now, I'm going to pull up a different view for us. Zoom back up here so that we can discuss the liver. Now, the liver has several important ligaments. Remember, ligaments are kind of double layers of peritoneum extending between organs or extending between organs and the abdominal wall. So the first ligament of interest is the falciform ligament, which is on the anterior surface of the liver, and it attaches from the liver to the anterior abdominal wall. It is continuous with something known as the coronary ligament, which I have now selected. The coronary ligament attaches the liver to the diaphragm superiorly. I'm just going to come back to an anterior view here. I'm just going to put in the diaphragm really quick here to show you have the falciform ligament, and though we can't see the coronary ligament, you could see how as this extends back posteriorly and superiorly, the coronary ligament would be able to attach to the diaphragm and thus make the liver and the diaphragm attached. And that's important because it helps create something known as the subphrenic recess. And the subphrenic recess is a superior extension of the greater sac, or the peritoneal cavity, or also known as the peritoneal cavity, between the anterior and superior surfaces of the liver or the diaphragm. You can actually see it here in my model. This is the peritoneum, and you can see how it extends all the way upwards and would extend between, once I remove the diaphragm, what would have been the diaphragm and the liver, and this would have been the superior recess. The boundaries of the superior recess are the coronary ligament, or in part are the coronary ligament. And the margins of this ligament, which is continuous with the ligament known as the triangular ligament, help show where the peritoneum, the parietal peritoneum, reflects back on itself to become the visceral peritoneum. Now that's not super well shown here because these ligaments should follow the peritoneum perfectly, as they are in part formed by the peritoneum. But essentially they help delineate that area at the back of the liver that's known as the bare area, where there is no peritoneum. And it is in this bare area where the liver is in direct contact with the diaphragm and the inferior vena cava. It's also a frequent site of hepatic abscesses, so it has some clinical importance. Now, the final thing I wanted to talk about in regards to the liver is something known as the hepatorenal pouch, or recess, also known as Morrison's pouch. I've heard it called Morrison's pouch more than I've heard any of its other names, so I'm going to keep calling it Morrison's pouch, but it's also known as the hepatorenal pouch or the subhepatic pouch. Now, Morrison's pouch is a potential space existing with the right kidney posteriorly, which I've highlighted here, and the liver anteriorly, which I've highlighted here. Now, and you can kind of see it. If I zoom in a bit and show you this angle, you can kind of see how there's this pouch here between the kidney and the liver. And I'm just going to zoom back out here. Now, the reason Morrison's pouch is important is because when a patient is supine, it is the lowest point of the peritoneal cavity. So when they're lying down, it's the lowest point, and you can have fluid like pus and blood and stuff like that accumulate there. Another reason it's important is that it's continuous with both the epiploic foramen of Winslow and the right lateral pericolic gutters. What's the right lateral pericolic gutter? Well, the pericolic gutters are 4 longitudinally orientated peritoneal gutters arranged vertically on either side of the ascending and descending portions of the colon. So basically you have the ascending colon here and the descending colon here. On either side of either colon, you have a gutter, or a pericolic gutter. Excuse me. Now, if I take that drawing away, if we look at the right side of the model, if we look at the right pericolic gutter, which is kind of right here, we can see that it is continuous with Morrison's pouch, which is right here, which is continuous with the epiploic foramen. And if we follow it inferiorly, the right paracolic gutter. Down, down, down we go. You can see that it is continuous with the rectouterine pouch of Douglas between the uterus and the rectum, as well as the pouch existing between the bladder and the uterus. Now, all of these connections involving the peritoneum, the greater cavity, and the lesser cavity, they're all very important because it allows for the movement of infectious substances, pus, blood, all throughout the abdomen and communicating with the pelvic cavity as well, or even potentially metastases. And so it's an important anatomical consideration to have, I guess, when you're thinking how would an infection move, say, from here all the way up to right behind the stomach, which would be the lesser sac. So that's everything for part 1 of my video. I've decided to split the video in 2 because it's rather long, but it is a pretty important lab and it does cover a lot of important substance. So the second video you can now check out, and this is the end of the first video.